Good afternoon. I'm Monica Hendrickson, the Public Health Administrator for Peoria City County Health Department, and welcome to our Tri-County update for COVID-19. As of Thursday, September 16th, the Tri-County currently has 50,801 total cases to date. That is an increase of 777 over the past week alone. Peoria added 390 cases to bring our total to 25,771. Tazewell added 316 cases, bringing its total to 19,480. And Woodford added 71 cases over the past week, bringing its total to 5,550. Peoria today is saddened to report 2 deaths. Both were males, one in their 50s, one in their 70s. Both were unvaccinated. That brings Peoria County's total to 391. Tazewell to 313, and Woodford County to 105. Our total to date is 809 deaths related to COVID. We're back to averaging above 100 cases per day in the Tri-County, with our 7-day average at 111 cases. Regarding our hospitalizations, for OSF St. Francis Medical Center, Unity Point Health, Central Illinois, we are reporting 13 ICU beds in use for COVID-19 and 60 non-ICU beds in use. The average right now of ICU beds in our Tri-County hospitals is 22. Regarding our vaccinations, Peoria County is so close to being at 50%. We are at 49.85% fully vaccinated. Tazewell County is at 49.54% vaccinated, and Woodford County is at 47.19% fully vaccinated. We have a couple of speakers today to kind of touch on topics that we are seeing in our cases as well as some of our investigations. And the first speaker we have is a nurse practitioner from Heartland Health Services, Jennifer Colettis, to talk primarily about maternal health and the importance of the COVID vaccine.
Thank you for the opportunity to speak today. My name is Jennifer Colettis. I'm a nurse practitioner at Heartland Health Services. I work exclusively in women's health. We care about the women in our community, so I'm here today to provide some education and reassurance regarding receiving the COVID-19 vaccine and pregnancy. I would first just like to say that we who work in obstetrics all have the same goal, which is a healthy mom and a healthy baby. We strive to do our very best to ensure a healthy outcome for all of our patients. And in order to stay current with best practice, we follow recommendations and guidelines from professional organizations that are dedicated to improving women's health, such as the American College of Obstetrics and Gynecology and the Society for Maternal Fetal Medicine. When taking care of pregnant women with gestational diabetes or preeclampsia, for example, we are following their guidelines. That being said, both ACOG and SMFM recommend that all women considering pregnancy and those who are pregnant, postpartum, or breastfeeding be vaccinated for COVID-19. Research has shown us that pregnancy is an independent risk factor for severe COVID-19 disease, and that pregnant women who have a symptomatic COVID-19 infection are more likely to end up in the ICU, need breathing support from a ventilator, or die. There's even a higher risk for severe illness if they already have risk factors such as diabetes, obesity, or advanced maternal age. New studies are now finding that COVID-19 may be associated with increased risk for preeclampsia, preterm birth, and other adverse pregnancy outcomes. I understand the fear of the unknown that many people have, and I especially understand this fear in a pregnant woman who wants to protect their child. And we just want you to know that we want the same thing. We want to protect you and your child. The data that has been collected on thousands of women is reassuring that there is no evidence of adverse maternal or fetal effects from vaccinating pregnant individuals with the COVID-19 vaccine. So I just want to encourage you to consider the fact that your baby will be born with a very immature immune system, and if you get the vaccine when you're pregnant, your antibodies are passed to the baby through the placenta, as well as through your breast milk, offering them some protection against the virus. Again, we're all on the same side. We all want the same thing, a healthy mom and a healthy baby. So please talk to your provider if you have any questions, or you're welcome to make an appointment with us at Heartland Health Services, or just come in to one of our locations to receive the vaccination. Thank you.
Thank you, Jennifer. What we're seeing in terms of our data right now is that within the population, especially our under 19 population, that is where we see most of our cases. Last week when we did our press briefing, it was just quite under 30% of our active cases were from 0 to 19. Today it is at 38.5%. Again, this population is accounting for the majority of our active cases. And because of that, we have to recognize the importance of getting them care as we go into the fall, the other issues they're dealing with, and kind of talk to it about in the scope of what it looks like in COVID with children. So with that, we have two speakers. The first is President Michael Wells for OSF Healthcare Children's Hospital of Illinois, followed by Dr. Keith Hansen, OSF Pediatric Hospitalist.
Thanks, Monica. Good afternoon, everyone. We appreciate the opportunity to be here to talk about COVID in the pediatric population and what we're seeing at the Children's Hospital of Illinois. As you know, there's been a lot of information in the media recently about the prevalence of COVID in the pediatric population, and some children's hospitals reporting a significant surge in their COVID inpatient population, so much so that their capacity is challenged. We have not seen that at the Children's Hospital of Illinois, fortunately. I'd like to just share with you a little bit about the Children's Hospital, what we're seeing related to COVID, what we're seeing in terms of some other infectious illness at the hospital, and then I'll turn over to Dr. Hansen, who's going to talk more about the clinical picture that we're seeing with our COVID patients and other infectious illnesses. First, for those of you who aren't very familiar with the Children's Hospital of Illinois, Children's Hospital of Illinois is a 136-bed inpatient hospital with all levels of care, from general pediatrics to pediatric intensive and intermediate care, neonatology, intermediate and intensive care, and a special unit just for pediatric cancer patients. Through our partnership with University of Illinois College of Medicine at Peoria, we have over 140 pediatric specialists that represent over 40 pediatric specialties. Just about any pediatric specialty that you can imagine we're able to provide right here at Children's Hospital of Illinois. We see about 7,000 annual admissions at the Children's Hospital and provide a little over 50,000 outpatient specialty visits through Children's Hospital of Illinois. We're the third largest children's hospital in the state. We are the largest children's hospital outside of Chicago. There is no other hospital outside of Chicago that provides the level of complex care that we provide at Children's Hospital of Illinois. We have 15 satellites around the state, and we provide neonatology or nursery coverage at 3 community hospitals in addition to Children's Hospital of Illinois. We have, in addition to our 15 satellites, we have televideo connectivity to a dozen hospitals that our hospitalists and intensivists provide consultation for physicians that are providing care in those community hospitals. Because of the level of care provided at the Children's Hospital of Illinois, we receive patients from across the state, really to the borders of the state, and anywhere outside of Chicago we receive patients from. Regarding COVID, as most of you are aware, the pandemic has had a relatively speaking, less significant impact on the pediatric population than on the adult population in terms of severity of symptoms, hospitalizations, and deaths. Unlike some of the other children's hospitals, as I mentioned, we have not seen a significant surge in our COVID inpatient population. Our daily average throughout the pandemic has ranged from about 0 to 3 patients on our inpatient unit who are COVID positive. We're grateful for that. We did see an uptick in our COVID positive patients at Children's Hospital last weekend. We went up to about 7. That dropped back down to about 2 during this week. I will say that we are currently experiencing a surge of other infectious illnesses, primarily RSV. Many of the kids that we're seeing are very sick. That has presented some challenges in terms of our bed capacity, especially in our intensive care beds. So I want to tell you a little bit about how we manage that capacity. What we're seeing in terms of the numbers of children in the hospital with infectious illness right now is very similar to what we see during the winter months when we typically have a surge of infectious illness. And so we employ the same tactics that we do during that time of year. We're continuously evaluating on a daily basis our bed capacity, planning for those cases that are planned, so surgical admissions, for example. Reevaluating, recalibrating the number of beds that we're going to be needing and how we're going to staff those. We redeploy staffing to the areas that need the most. We bring on temporary staffing when we need to, so hiring temporary nurses or other staff to take care of patients in the hospital during those surging times. We make sure that there aren't any unnecessary delays in discharges so that we're able to open those beds up for patients that need them. And when needed, we do have a unit in the hospital that's a swing bed unit, so can function for adult patients or pediatric patients. And during our surge times, we're able to expand completely into that unit so we can open the entire thing up for pediatric patients as we need to. So we're being vigilant, we're staying on top of our capacity management, and to date we've been able to to keep pediatric beds open for all those pediatric patients who need us. I will say, just in closing my comments, and then I'll turn over to Dr. Hansen, the uptick last weekend was somewhat alarming. We are reminded that we're not out of the woods yet. We all wish that this was behind us, but it isn't. And so we encourage you to continue taking precautions, masking, social distancing, good hand hygiene. We also encourage everyone who's eligible for the vaccine to please get it. I'll turn over to Dr. Hansen, and then we'll take questions.
Okay, thank you, Monica, and thank you, Mike. So again, as I mentioned, I'm Keith Hansen. I'm one of the pediatricians at the Children's Hospital of Illinois and the University of Illinois College of Medicine here in Peoria, and I primarily take care of patients in the hospital. And I just wanted to speak, along with Mike, about the differences between some of these viral infections that we're seeing, because you may read in the news about different things like COVID surging in pediatric patients and RSV and things of that nature. As Mike mentioned, COVID generally over the last year has really been quite mild in kids. Most infections in pediatric patients are mild or asymptomatic, though there are, of course, some kids that have had severe illnesses. But overall, here in Peoria, we haven't really seen a surge of significant serious illness related to COVID. Even when we see increased numbers in pediatric patients, as we've been seeing recently, the illness overall is pretty mild or even asymptomatic. However, as Mike said, we are seeing more patients admitted now with other viral infections like RSV or rhinovirus, which we typically do see more in the winter months. We're just seeing those a little bit earlier now, probably because everybody's being back together after a long time apart. People didn't get exposed last year, don't have that immunity built up. So we are seeing more patients with other viral infections, in particular with RSV. It's really hard to tell, when a patient maybe or your child has fever, cough, runny nose, difficulty breathing. Do they have RSV? Do they have COVID? When should you be concerned? And it is very hard to tell because all of these are respiratory viruses. So it's really important if your child or family member has symptoms that could be COVID or RSV to get them tested and to find out. Back in the day, we didn't really care too much one way or the other which virus it was, but now it's really important to know, is it COVID or is it something else just to prevent the spread? And so any of these viruses could present similarly: fever, cough, shortness of breath, just kind of runny nose, could be really anything, fatigue. It's important to kind of figure out which thing it is, just for those public health reasons. In the hospital, though, we're not seeing many kids admitted with severe COVID. The ones that we have seen tend to be teenagers that are unvaccinated and have other medical comorbidities, which we're kind of seeing nationwide as well. RSV, on the other hand, when kids are hospitalized with that tends to be younger patients, typically less than age 2. And so when we look at the hospitalized patients, there's a little bit of a difference, but at home it's really hard to tell, and that's why it's important to get tested. Not every kid with RSV or with COVID has to be in the hospital. It would only be if they need some kind of support or medication they couldn't get at home, either from oxygen or fluids or medications. And so just because a patient has COVID or RSV doesn't necessarily mean they have to be seen or admitted to the hospital. And in fact, if you're COVID positive and you don't need to be in the hospital, we'd rather you stay at home and do those quarantine precautions to not spread things around. So the bottom line is we are seeing more respiratory viruses right now, a little bit earlier in the year than normal. These are things that normally we see November, December, January, and they're coming on a little bit earlier. They're not necessarily all COVID, but it is hard to tell, and so that's why it's important to get patients tested, make sure everyone's wearing masks, taking precautions, getting vaccinated if you're eligible to prevent the spread of that virus in the pandemic. So I guess we can take questions now. Mike as well. I'll put my mask back on since you're coming back up.
So I guess you're saying the majority of the severe pediatric COVID cases you're seeing are among unvaccinated teens. Did I hear that correctly?
Yeah, that's been this kind of surge recently that Mike talked about. It does seem to be in the teenage patients that have been a little bit more the severe illness recently. You know, over the whole course of the pandemic, we've seen younger kids are not as affected as adults, and so the teenagers are functioning kind of more like adults in that way. And the data is going to be the same as we see in adults. When you look at hospitalizations nationwide or in Illinois or in Peoria, 90% or so, or an estimate, are now unvaccinated patients, and that's going to be the same in the teenagers as well. You know, kids over age 12 are eligible, and so we really encourage people to get vaccinated for that reason. So, yeah, the unvaccinated are going to be at higher risk for severe illness and hospitalization.
So, but with children that are 12 and under, unable to get a vaccine at this point, you aren't seeing the unvaccinated severity in those younger children, though?
Right, we're not really seeing the severity of the illness for COVID, in those younger kids, and that's been the case for the whole pandemic. Even when they are positive, they tend to be kind of mild symptoms or asymptomatic. So we're not really seeing the severity of illness in the younger population. The kids that are admitted sick right now in the hospital at that age are really with RSV and those other things that are more typical viruses for us.
Can I just add one thing? Even though the total number has remained low, I will say that the concern in the pediatric population is similar to that in the adult, in that people who are especially vulnerable, have chronic illnesses, are those that are at greatest risk. And those are the ones that we worry about a lot, right? And as a children's hospital, as I mentioned earlier, we provide a high level of complex care, so we're getting kids from across all of the state. And so those are the kids that, kids that are being treated for cancer, kids with severe asthma or other chronic illnesses, congenital heart defects. Those are the kids that are at great risk. And so we just encourage people to protect them. And if it's not for yourself, do it for them.
So you spoke a little bit about how RSV and rhino have the same kind of symptoms as COVID, and trying to decipher in between those is really important. Can you touch on that again?
Yeah, so you're asking about COVID virus versus rhinovirus or RSV.
Yeah.
It can be really hard to tell, especially in those patients where, like a lot of kids do, that's just mild illness. So it can just be fever, runny nose, cough, congestion, respiratory distress, that sort of thing. And it's hard for the parent or even the general pediatrician to know which virus it is, and that's why we encourage testing so much so that we can know. When we look at the hospitalized patients with severe illness, it's a little bit more clear, again, because there is that age difference where the teenagers tend to be the ones with COVID, younger kids with RSV. COVID, in my experience, has a little bit more fever, those higher fever, a little bit more of that general fatigue, dehydration. RSV tends to be more respiratory distress that we see. That's a generalization. There's a lot of overlap, and that's why it's important to kind of get tested. They're all respiratory viruses, and not to go into too much depth, but even before all this, there was coronavirus strains out there that caused these same illnesses, and now we have COVID-19, which is a new strain. So they can all be very similar, and that's why it's challenging, in kids and adults both. So if you have any concern about your child or family member, fever, runny nose, cough, it's always worthwhile to get tested so you can kind of differentiate early on what's going on.
Is there any of the three that's more, dangerous for children?
I would say not particularly. Every patient's a little bit different. You can have a patient that's really sick with RSV, really sick with rhinovirus, really sick with COVID. It's all about the particular patient, whether they have any other medical complexity, their previous exposures and things like that to those viruses. So they could be sick with any of the three.
Can you get tested for RSV and rhino? Like, you can get tested for COVID?
Yeah, you can get tested for all those things. So, if you go to your run-of-the-mill urgent care or Walgreens, they're doing the COVID test now broadly. But if you were really sick and went to see your PCP, there's rapid tests for RSV and flu both. In the hospital, we do have a comprehensive viral panel that tests for the most common, like 12 or 13 viruses, and they'll all be on there. So usually we're doing that test when we have a patient in the hospital because we want to know which one it is, because the treatment may be a little different, the isolation may be a little bit different, and things like that. So there are testing for those things.
So it is important to know which one you have because the
Right. It's important, especially, I guess I meant more in terms of the isolation and the quarantine. I mean, you want to know if you have COVID-19 so you can be sure to isolate and prevent the spread. The treatment may be different depending on the situation. Generally speaking, there's not much specific treatment for RSV or rhinovirus. There may be for COVID in those older patients with severe illness, but most patients with kind of mild to moderate illness, especially those that are at home, aren't getting any particular medical therapy usually.
Thank you so much.
Yeah, you bet. Okay, thanks.
I'll also open up, are there any questions for our nurse practitioner? If not, any questions for myself?
Monica, you said that there's a pretty precipitous jump this week between 30 and 38%, you said, for people under 19. How's that going in schools? You know, I know you said last week that a lot of these infections aren't happening in the schools, but they still end up at school. So what is happening with that?
So, the jump that we saw from 30 to 38% over the past week, really talks about the fact that there are more congregate settings for children of that age, regardless of just school alone, which is much more indoor, but other school-related activities, so sports, dance teams, things of that, independent from just a school setting. And I think that's really important to note that majority of our cases we are seeing is not happening in classroom to classroom spread. It's not because Bobby and Jill are sitting beside each other. It's largely because of what happens outside of the school setting, which is that they might be on the same sports team or doing an after-school activity where the amazing number of mitigations that our schools put into place, such as universal masking, testing, all of that, doesn't happen in those settings. And by default, our schools are feeling the burden of when mitigation is not followed at these outside settings. And so, again, we're not surprised to see the jump. But I think one of the data points that the state had shared recently with us is that if you look at the trajectory of cases, and you first group it by age range, and then you group it by vaccinated versus unvaccinated, the sharpest incline that we have seen is unvaccinated youth. Overall, age ranges that are older or even, middle age, relatively the same. Overall, the unvaccinated is at a higher rate of cases than anyone that is vaccinated, but the steepest growth we've seen is in that youth population. So again, if you have a child that is between the ages of 12 and 19 and medically able to get vaccinated, get vaccinated.
Well, can you break it down to numbers when you say that, that 8% jump? I mean, is it, do you know what age group? Because, the doctor is saying that the young kids, it doesn't really hurt them, but it's the older kids that they might be seeing in the hospital. Are you seeing the jump more in, 9 to 15-year-olds or?
So we group in by decades, usually is how we like to operate. Our largest group, about 25% of that number. 25% is going to be the age group of 10 to 19.
Okay.
And then the remaining difference is below, so 9 and younger. And again, that 10 to 19, largely, except for 2 years in there, are eligible for the vaccine. So it's highly preventable in that age range. And I think what's really important, and to the questions that the other media had asked about the different types of viruses you see in youth, rhinoviruses and RSV, we see them in the population. They're not novel. That's the big difference. COVID-19 is novel. No one has immunity to that. And that what makes the key difference. So it's not the severity of the issue, it's the fact that once it spreads, the individuals that are getting it, unless they're vaccinated or maybe been exposed prior, don't have a built immunity to it. And so something like RSV or other rhinoviruses that can naturally progress through the community, we don't quarantine or isolate because of a rhinovirus or an RSV exposure, because so many of us have had it in some capacity in our lifetime. But COVID-19 is completely different because it is novel. And that's why it's so important that you get tested for it so that you not only protect yourself, but you protect those high-risk groups that might get exposed.
When you said 25%, what was 25% of new?
So of our current active cases in Peoria County, over 25% are between the ages of 10 to 19. And the remaining 13.5% are from 0 to 9.
So with the rise in the pediatric cases overall, but the hospital saying they're not seeing a major inpatient with pediatrics. Most of these children that are isolating at home, I would assume that is it.
Majority of our positive cases of adolescents and youth are isolating at home, which is great.
I want to touch on vaccines for a little bit. There's been some conflicting views about who needs a third booster and when. Is there any indication that people who aren't immunocompromised will need a third booster shot anytime soon?
I think we're all waiting for ACIP or the advisory group to come out with clear guidance on how we want to implement this. I think a lot of the dilemma that is created is in a variety of levels. One, let's just take a step back to realize that we live in a country where we have easy access to vaccinations, and this is still a global pandemic. So part of the argument that comes into place is sharing resources. The other part of the argument is immunocompromised individuals versus non-immunocompromised. Clearly, though, that does mean you need to have a diagnosis, a known medical history, and a lot of people don't. They know that they don't realize they're immunocompromised or at higher risk. So I think it's a layered response, and that's why we are looking to see when the FDA reviews the data as well as ACIP, what are the clear defining guidelines as to why someone should get a booster vaccine. Right now, we see clearly for those that are diagnosed as immunocompromised, it is important for them to get the booster. And that makes sense just because of their health condition. It's the other individuals that we do need to understand, and it might come down to risk, age, all those other type of activities that put someone at a higher mortality and morbidity for the virus can play a role in whether or not they need to get a booster. So it's not as simple as you meet these boxes. There is going to be a lot of variations that happen. But the end of I think the moral of the story is if you have received 0 vaccination and you are eligible, you need to get at least that first round of vaccine in you.
And locally, are we seeing any racial disparities when it comes to COVID-19, like hospitalizations, deaths, especially minorities? We've seen kind of across the country in other parts of Illinois, African Americans and Hispanics. We've seen that hospitalizations have been higher for them. Are we seeing any of that locally?
So, throughout the response, we've seen variations of racial disparity come into play. I think early on, nationally, we've all saw that a minority population, black and brown, were disproportionately impacted in the first few months of the virus. But this virus does not discriminate. It goes against everyone. And so we saw that then kind of start following along with the general demographics of a population because that's how the virus operates. What's interesting now, and this is where the conversation is is that you have higher levels of vaccine hesitancy amongst minority populations. And so are we now seeing our most active cases be minority populations because they are not seeking out the actual medical or pharmaceutical intervention to prevent them from getting ill? And so, I ran the data because I think you might have emailed us earlier. But I would just kind of looking at our population, especially our youth population, the under 19, a fourth of our 0 to 9 cases are amongst Black individuals, and a third of our 10 to 19 are amongst Black individuals, which is higher than the natural geographic or demographics of our county. So to that point, you see that we have a lot of cases amongst our minority population, but we also have low vaccination rates amongst our minority population at the same time. So it's a really interesting and complex problem because, which came first, right, is kind of what it comes out to. And so at the end of the day, vaccines work, and we've been at the health department actively trying to pursue it in all parts of our community, especially our high risk and our minority populations, because we understand historically there has been issues around accessing healthcare as well as hesitancy around healthcare and vaccine in particular. And so we don't want them to be a statistic. Rather, we want to be them informed and be able to take healthcare into their own hands.
Have you been getting any inquiries about religious exemptions for the vaccine? And if so, what kind of guidance are you offering? I would imagine that would be employers.
So we do know that we're in kind of a new realm of vaccine hesitancy as well. We're seeing a lot of employers seeking out vaccine policies. Our health department is one in particular that's also doing a mandated vaccination. And so we do have a medical and religious exemption. For our religious exemption, we do walk through and we just kind of want to understand the process behind it. And then work with them to make sure that there is any type of accommodations that can be made. We do know from the fairly qualified health centers that have done some research on it, there have been 2 religious groups, organized religious groups, that have come out. But I think it's really key, and this may be a question for an attorney more than anyone, is that there's also moral obligation, which doesn't necessarily assign to a structured or organized religion either. So, these are things that we are working with at the state level, and the state's working with their legal on interpreting this as well as here locally with all of our legal counsels as well.
Because there have been area churches that have come out and told their members that they would give them a written exemption. Are those going to be valid?
We've just had area churches, that communication has come to. We've also had physician offices that have, you can go on the internet and for $40 buy a waiver note these days. And so, we do our due diligence when we get it. I can speak at the health department. When we receive any exemptions, we walk through it with them. We walk through the paperwork they have submitted. If they provide a medical one, we even walk through it with their physician. So there's a lot of due diligence to go through this process. I think the challenging part about this is that then, accommodations. If we decide to make accommodations and we acknowledge this type of exemption, those accommodations can be very, very difficult on employers. And so we want to make sure that we are doing what's best for our community and the safety of our clients.
And when you say accommodations that would be difficult, can you be specific what that would mean?
I can speak to, just ones that we've seen through different listserv groups or different conferences, conversations, the amount of testing, the type of testing. Right now, a lot of our testing is nasal. Some religious groups are adding that they can't do nasal testing because it also is a part of the same moral obligation, which is really difficult because saliva testing is very, very limited. And so, again, I think we can only do so much for accommodations, and so we just are walking through each of those cases one by one.
And have we decided the expense of it? Are employers going to be expected to pick up the expense, or do we know yet?
I think that's a question that we've also asked our legal as well about the expenses of some of these exemptions, and I know our school districts are in the same boat. So it is a kind of a new era for this vaccine campaign where we're going through mandating vaccines, and there's going to be, again, also more hurdles to come as well.
In terms of the exemptions, if somebody has, a long-standing where they've gotten exemptions for all their flu vaccines and all the things, if they work for the hospital or whatever, those would probably be honored. The COVID would be honored. Would it be any different for COVID than it is for these other exemptions?
I can't speak to hospitals or other settings. I do know, for example, certain positions, because of OSHA requirements and the risk of those positions, that we tell an individual upon hire that, you're going to be working with bloodborne pathogens. So having your hepatitis series is very key. Is that something that you can do? Because there's also a risk to us as employers in that scenario. And if they, upon hire, aren't able to, or during the interview process, aren't able to meet that, they don't usually go further into our employment, because up front we have to meet those OSHA and those best practices as well. So, okay, I think we meet again next week for our briefing, and I think we are here. We can actually maybe do that one offline too. Okay, thank you.